it very rapidly eliminates dabigatran from the system. So based on these data, the FDA actually approved itacitinib for reversal of dabigatran. It's given as 2.5 gram IV boluses, no more than 15 minutes apart, and is very effective. All of our centers should carry this in the pharmacy. For the direct 10A inhibitors, these are things like apixaban, rivaroxaban, edoxaban. There's this R antidote. It is a recombinant factor 10A molecule that is, again, catalytically inactive but binds with high affinity to the factor 10A inhibitors. So it takes them out of the equation without actually having its own effect on the coagulation, so you also can't make patients prothrombotic. Here we can see a schematic of how this works. In patients taking a direct 10A inhibitor such as rivaroxaban binds to the prothrombinase complex and inhibits it, so you can't convert prothrombin to thrombin. When you give this R antidote, it actually binds rivaroxaban with high affinity. It leaves the prothrombinase complex alone, and now you can convert prothrombin to thrombin. This has been studied in a number of trials, one of the most recent ones being ANNEXA-4, which shows that andexanet alpha given as a bolus and infusion actually is very effective at reducing the effect of the direct 10A inhibitors. So when it comes to the overall algorithm for managing the NOACs in patients who have severe life-threatening bleeding or need emergency surgery, if you're certain that their last dose was sooner than 12 hours and you think there's still an anticoagulant effect, if it's dabigatran that they've taken, you can give activated charcoal if it's under 2 hours from the ingestion. You can also dialyze, but there's really no need to pursue dialysis now that we have itacitinib, which works quite well. For the direct factor 10A inhibitors, we use 4-factor PCC until we get andexanet alpha more widely available. Some of you may have clinical trials evaluating andexanet alpha at your center. You can enroll patients in those trials to get access to it. So in summary, the short half-lives and enhanced safety of the NOACs compared with warfarin are likely to facilitate actually interruption of anticoagulation in the setting of procedures and bleeding in vascular surgery patients. Limited data and varying strategies for interruption of the NOACs presents a current clinical challenge, but as we get to using these agents with more experience, we're going to get more comfortable. As I mentioned, greater experience, the development of commercially available assays of NOAC activity, and the approval of reversal agents were likely to dispel much of the uncertainty surrounding the management in the perioperative setting. Thank you very much.
I have a question before we go to the audience. So you mentioned that one should try not to combine a NOAC with aspirin, but they have different mechanisms of action. So can you,
Sure.
Could there be many patients with stable angina who have AFib? Would you not need both?
No, so if patients have a solid indication for being on aspirin, they absolutely should be maintained on both. But when we see patients who have no known cardiovascular disease and are just on it because they heard it was something good to take, we should be responsible for actually removing it when it's unnecessary.
Greg, again, great information, really outstanding. I don't want to make you go too long, but maybe you could say a few words about some of the studies looking at NOACs, particularly in peripheral vascular disease and peripheral vascular intervention, some of the studies that we're waiting to hear about lower doses in peripheral intervention.
Yeah, so that's a very hot area of study right now. There have been studies evaluating, we even have back in the warfarin days looked at warfarin for the peripheral vascular disease patient, and the hope is that these agents are actually going to really revolutionize the management of PAD patients. One of the things that comes up frequently in my clinic is patients who repeatedly thrombose grafts. Those patients may have some underlying procoagulant state, and these anticoagulants may actually play a key role. We've seen some agents that kind of skirt the realms of antiplatelet and antithrombotic agents like Vorapaxar actually have some role in the management of PAD patients. I think this is an area that we can stand to make a significant inroad in. We're all looking forward to the further trials to evaluate antithrombotic therapy for the PAD patient.
Thanks for all the information. That's great information. Just, I think I have available Octoplex, which is that 4 pp. I'm just reversing the 10A agents. I was told that the Octoplex is not really very good for that. And so my question is, how good is it? And then if the Octoplex works, why doesn't FFP work? And just, I don't know, I can't remember all the basics.
Sure, no problem.
Just simply.
No, it's an issue because 4-factor PCC's really not been the subject of robust randomized controlled trials for reversal of the anti-10A agents. Although in animal models, healthy volunteer models, and some small trials, it appears to be effective. It's not clear how much you really need to give. It's not as sure a thing as it is with warfarin. It's for that reason that we're really looking forward to andexanet alpha, which seems to do a better job of reversing the 10A inhibitors than PCC.
This program contains graphic images and discussion of medical procedures. Viewer discretion is advised. Well, as they say where I'm from, an ounce of prevention is worth a pound of cure, so Although my title is The Treatment of Type 1 Endoleak, I'm going to actually talk about a very similar spectrum of problems, but at the other end of things where they can influence the original outcome. My disclosures, as always, I've licensed the patents to Cook, and they support us with research grants. The problem with type 1 endoleaks lies, as with any other type 1 endoleaks, not so much with the stent graft or often with the implantation, but with the anatomy. It's a problem of mismatch, but when the anatomy is distorted, the stent graft is often unable to match that. Here you can see in a little array of aortas, the point I'm trying to make is that nearly every aorta at that point, the transition between the arch and the descending thoracic aorta, has an acute angulation. And if that is where you're trying to implant, you're going to run into some difficulty. Now, what about the option that we usually have is just going more proximally? Well, there you're limited by the presence of some vessels supplying organs with very poor tolerance for ischemia. So, here we have the unfavorable Gothic arch where the descending and aortic arch meet. There is an acute angle, and the acute angle often exceeds the capacity of the stent graft to bend. So what can you do about it? Well, here is a stent graft that I thought had the most promising chance of providing us with a solution up in the thoracic aorta. But what I'm actually depicting here is an abdominal aortic device. They never got so far as to make a good thoracic aortic device, but it has a couple of features that you would like to see. One is it's very flexible, and the other is capable of implanting in a very short segment of non-dilated aorta. Well, what else is out there? Here's one of my favorite stent grafts, mainly because it's low profile and easy to put in, but also because its design and the design of its delivery system tend to allow it to accommodate that angle at the distal end of the arch. One of the things that help to do that is an uncovered stent that extends the segment that is imposing an orientation on the proximal end of the stent graft. Now, I was actually the first one to write a paper on what happens when you put pointy stents into curved, mobile, compliant pieces of aorta, and the answer is they erode their way through. Well, this particular stent graft, as they offer from Cook, has stents that are like the arches on an aqueduct. You know, they have soft tops and sharp bottoms, and we have not seen any ill consequences of that design. Flexibility, obviously, is something that you'd like to build into your stent graft. The only problem is that you want to combine flexibility with a secure attachment, because there's only two things that hold these grafts in place. One is the attachment, and the other is stiffness. And if the device has no stiffness and it has no attachment, the big hemodynamic forces that act on the proximal end of the stent graft will make it sit down inside the aorta. And that is something that you have to bear in mind when you're treating these short necks and big angulations. Okay, well, I said you can't march into the aortic arch. Well, that's true, but you can't do it without providing an alternative flow to these supra-aortic trunks. And how much you need to do depends on how much aorta you need to steal from the arch. So people get ever more aggressive until they find themselves in CT surgeon's territory. And you know, this for a long time was sort of a standard solution, but you certainly pay the price for obtaining your inflow from the ascending thoracic aorta. Well, what about the option of obtaining your inflow from the ascending thoracic aorta without actually operating on it? What I've depicted here is the snorkel approach, or what we termed when we first discovered this. Not that we were the first to discover it, but we discovered it in a case where proximal end of the stent graft ended up more proximal than we wanted it. Is just put a stent in there and then channel flow into the arch vessel. Equally valid is to put the stent graft downstream and channel flow from there. Here you can see sort of an extreme version of this where all the flow is going in the armaments, and a collection of bypass grafts is being used to distribute it through the brachial valve circulation. And the problem with these, and the problem with all of these, is gutters. When you're trying to match two circular objects, or three or four, inside a circular object, you're not going to create a gap-free environment, and blood can leak through these gutters, and if that happens, it's a problem without a remedy. You're really stuck. Well, one of the things that people have discovered is that gutters are avoidable, but you can mitigate the effects of the gutters. The longer they are, the less likely they are that the column of thrombus that lines them will transmit enough pressure to undermine the stability of the repair. Now, what happens if you don't have a long segment of non-dilated aortic proximal where you want to repair? Well, you can make one by putting in a stent graft in that approach, where you put a stent graft in, then you put the snorkel and you put another stent graft is described as a sandwich approach. And people have written enthusiastically about the results of this approach. I just caution one more time, though, if it fails and there's a leak, there's nothing you've got to do about it. And the leakage rates in these things are about 20% primary leakage rates. Most of them seem to be you have to wonder what the pressure's doing. And I put here just to show you that I actually do know how to open a journal. Not that I believe anything I read there. Okay, well, what about the cardiac solutions? I mean, really, we'd hate to see them left with nothing to do. And they can provide you with a nice, solid platform on which to base the repair of a descending thoracic aorta. That is, if they put their elephant trunk into the proper lumen, they sometimes have to be reminded that the true lumen is where we want the elephant trunk to go. If they put it in the false lumen, it gets a little hard. What about the completely endovascular alternative? This, like many other things in complex endovascular repair, was pioneered by John Anderson in LA. Down here is a couple of fenestrations, one for the arm and one for the left carotid, and he lined them up with the target vessels. That is unbelievably difficult to do. This guy was a genius. He can do it. I wouldn't recommend that anybody else try. Slightly different approach pioneered by Inouye and a bunch of Japanese guys also calls for a certain amount of genius in that you have to have a simultaneous deployment of three branches and a stent graft, all without traumatizing the inside of the aorta enough to cause embolism. Didn't work. This was one of the approaches that we tried in a series of prototypes. that we tested in a rubber model. But what we finally concluded, actually what Nash finally concluded, was that the version that was going to work best was the simplest, which is probably a good rule to follow. And this is the one that we used. It's basically an upside-down bifurcated graph that we put in through carotid artery. It worked very well. The long leg trailed into the innominate, the short leg was extended into the aorta. The result of bifurcated graph was augmented with some pretty tough bypass, and this guy did very well. Unfortunately, this is an approach that we could apply very widely because you need to have a big carotid and a small aorta. That's not a common combination of patients who have aneurysms and dissections. So here's the anatomy. We were very happy with it. The patient was very happy with it. But an approach that has proved to be more successful is the multi-branched approach with transfemoral insertion of the primary component. Here you can see that this was a patent in 2000. I mean, this is an old idea. It took a couple of years to get going. This was Cherry Abraham's version, where it was with a cow catcher on the outer aspect of this attachment side. The problem with that is if you put it in right, it was great. But if you put it in a little bit off, you couldn't get to where you wanted to go because the cow catcher was in your way. So we went with this approach, where there were these little landing pads that led you into the inner cuffs. And this was the patient we treated. A little old lady weighing 90 pounds who'd had her thoracoabdominal done already, and we did the arch. Turned her into a complete full metal jacket with a very high pulse pressure. One of the things that enabled us to do that was a self-orienting sheath with a curve built in it. Now, as you might imagine, this is a dangerous area. Complications are bad, and many patients get strokes. Or at least they do early in the experience. If you look at the learning curve, it's very steep. People have now extended these kind of techniques into the treatment of dissections, type A dissections. As you know, cardiac surgeon's preference is to put a short ascending thoracic stent graft. That can be a difficult target. One of the ways to deal with that is to actually put a very short nose cone on the graft. You could now make this as a standard device. It's one of the sad things in life is that many of the things that were invented here are now routine in Europe, and they always have better equipment than we do. Here are various alternatives, similar approach, working their way through the product testing and approval process. Don't expect to see any of that. So here's a slightly original approach where the added component is not going to the arch vessel, it's going to the ascending thoracic aorta, but essentially the same concept. But just to finish on a note of caution, the enemy is, and always will be, when working in that part of the body, embolism. Hence this little collection of devices, the Umbrella and others, that are all designed to prevent embolism, because that piece of aorta is often rather shaggy and will throw little pieces of epicuroma into the cerebral circulation. So I'm not there yet, but we're getting there. Thank you. This program contains graphic images and discussion of medical procedures. Viewer discretion is advised. These are my disclosures. I think the first thing we need to do is to define the pathology. So an intramural hematoma is really the formation of thrombus in the aortic wall with an absence of a visible intimal tear of blood flow between the layers. It can occur anywhere in the aorta, and it's labeled type A and type B just the same way as dissections. It usually presents with sudden onset of chest pain, upper back, or abdominal pain. It mimics aortic dissection in its clinical presentation. Hypertension is almost universal, and it's refractory in about 30% of patients. About 5 to 10% of patients can present with spinal cord ischemia at the initial presentation, and it actually may be an incidental finding when a CT is done for some other pathology. Now, the initial management is very similar to aortic dissection. It is conservative, and it implies control of the blood pressure, usually with beta blockers initially, and pain control. This is conservative management, except that the maximum aortic diameter is greater than 4 centimeters, in which case rupture can occur. If there's a pleural effusion at presentation, which implies some degree of seepage, it can be just serous fluid from a very, very thin outer layer. And in patients with intractable pain and refractory hypertension, and again, you can see how difficult it is to define intractable and refractory, but it can be a patient where you're trying to control the hypertension and you can't do it, or patients that require increasing doses of opioids for control of pain. Now, it is recommended that you do on conservative management that you do serial CT scans on the first day, at day 4 and at day 10, and that allows you to determine if the patients that you initially try to do conservative management are failing the conservative management. So just a couple of things to look for on the follow-up CT scans. You have ulcer-like projections, of which you can see here, and basically this looks like a penetrating ulcer. However, the difference is usually in penetrating ulcers you have plaque accompanying the finding, whereas in these you have no plaque and it's part of the intramural hematoma. You can also see what's called an intramural blood pool, which are areas of focal contrast enhancement within the intramural hematoma without lumen communication. And you can see an example of this here. You can see a couple of blood pools right here. And these are things that you would look on the CT scan follow-up, and if one of these develops, it would be an indication for intervention. So the question is intramural hematoma different than aortic dissection? This is actually a patient that we saw at UCLA, patient who presented with this intimal tear and almost thrombosed what we call false lumen. 6 weeks later, it was all healed up, and all you saw was the intramural hematoma. So the question is, if you see this patient at this time, would you call it an intramural hematoma or an aortic dissection? I would submit to you that this is probably a continuum of disease. It is a similar pathology in the aortic wall. It's just a different type of presentation. Here's a patient of mine that I saw in 2014 that presented with what appears to be an intramural hematoma, has some blood pooling and what appears to be dissection in the lower abdomen. She was actually asymptomatic at the time of presentation.
So we decided to treat this patient conservatively. Here she is in 2015. The thoracic aorta is all healed up. She has some blood pools in the lower abdomen, and the dissection appears to have been converted into some blood pools with the intramural hematoma. Again, the patient remaining asymptomatic. Here's the same patient in 2016, and now she has what appears to be an area of small intramural hematoma, but the aorta is completely healed. And here she is just last month, a couple of months ago, where the aorta is completely normal. What was interesting in this patient is on this CT scan, I actually looked at the CT and was very happy and told her about that the aorta was completely healed. And it turns out that on the same CT scan there were some pulmonary emboli that were detected, and she was asymptomatic from that process also. Turns out she has a hypercoagulable condition. If we look at the IRAD registry, they reported on 107 patients with intramural hematoma, and the conclusion was that most of these patients can be treated medically, and the aortic enlargement is less common, and the process has much less complications compared to the dissection, defining what they call a more benign course. So what are the indications for endovascular intervention? Increased intramural thickness on follow-up CT, extension of the intramural hematoma, new ulcer-like projections, new aortic wall pull, intractable pain, and refractory hypertension. Those are clinical indications that intervention may be indicated. Now, when you look at the natural history and which patients end up with intervention, about 75% of the patients require a continued conservative follow-up, whereas 25% of the patients end up undergoing TEVAR without any further imaging at initial presentation. So what are the considerations when you're using an endovascular graft for intramural hematoma? You do not want to exceed more than 10% oversizing. Covering all affected aorta is the ideal intervention. If it's not possible, be aware that you can cause a new tear and the extension of the intramural hematoma. I actually had a patient several years ago that had an intramural hematoma starting about 10 centimeters from the, it was about 15 centimeters from the left subclavian artery. I just placed the graft just above that, and 3 weeks later she presented with retrograde intramural hematoma into the aortic arch. So it does happen. So you want to make sure that the proximal landing zone is in a healthy, normal appearing aorta. You want to avoid ballooning, and retrograde dissection is clearly a risk, and I would avoid bare metal proximal stent configurations. So in conclusion, I think intramural hematoma may be a continuum of medial aortic pathology that involves dissection. Conservative management is the first line of therapy with control of hypertension. TEVAR is indicated for specific both acute and subacute indications. About 25% of patients will require intervention on initial presentation, and the rest of them can be managed medically. I think close follow-up is indicated in all cases. Intervention of choice is an endovascular intervention, and today the need for an open repair is very rare. I see that Dr. Starnes just got up to ask a question, so I'm starting to get a little nervous here, and I thank you for your attention.
William, congratulations on a very nice presentation, a thorough review of the literature. You provided that one anecdote at the end about the risk of retrograde propagation and development of an intramural hematoma. I've actually had the exact opposite. I'm not diminishing the risk of retrograde dissection, but I had a 55-year-old guy that came in who had a small entry tear that we could identify distal to the left subclavian, like you said, but had intramural hematoma that extended all the way across the arch and all the way down to the aortic valve, and it was 8 millimeters in thickness circumferentially. Our cardiac surgeons weren't interested in doing anything for this gentleman, so we actually put in a stent graft and just covered that entry tear, and in about 2 weeks, the intramural hematoma that was around the ascending was completely gone. So I'm wondering if you have had a similar experience to that, or if anyone else has, because it's an interesting phenomenon.
No. The question is whether it wouldn't have behaved similarly without the TEVAR, because like I put in that first case, and even in the patient with the follow-up, I mean, these things, it's interesting how they can behave over the course of time. I mean, this patient that I saw in 2014, I just saw a couple of months ago, is a prime example of if the patient is asymptomatic and the blood pressure is adequately controlled, there's healing that occurs in the aorta. So, it's hard to tell. I would be very leery of putting an endovascular graft in an area where there is intramural hematoma, because I think the intima and whatever media is left attached to the intima is very fragile, and I think you can create a tear. So that's a difficult case to sort of know exactly what's the best way to do. Thank you.
This program contains graphic images and discussion of medical procedures. Viewer discretion is advised.
Good morning. The first slide is my disclosures. So this morning I'm going to talk about medical management of peripheral artery disease, both to reduce rates of cardiovascular events and also to improve walking performance. So with regard to reducing cardiovascular events, secondary prevention should focus on statins, smoking cessation, antiplatelet therapy, blood pressure control, and for walking performance, exercise and medications are what I will be discussing. So first, reducing cardiovascular risk. It is well established that statin medications reduce rates of heart attack and stroke in patients with PAD by about